pain for the past 15 days and difficulty in eating for the past 6 months. So history of presenting illness, he developed fever before 1 month, so moderate grade fever up to 100°F with no chills and rigors, more fever and pain, intermittent relief medications. He developed cough with expectoration for the past 15 days, minimal quantity, not bloodstain. He also developed left chest pain for the past 15 days. It was pleuritic type. The pain increases while breathing. There was no radiation of pain, no palpitations. So past history, he was a known case of bullous disorder from 3 months of age. So diagnosed as junctional epidermolysis bullosa in 2016 in CMC based on epidermal bullosa panel multiple biopsies. So he has history of taking Ayurvedic medication for skin condition from 2018 to 2021. So personal history is not significant. So no family history of similar conditions. So in examination, his blood pressure was 110/70 mm mercury, heart rate of 102, saturation he was maintaining at room air 98%. He was febrile at examination of 100°F. So no eschar was there, no pallor, icterus, clubbing, cyanosis or pill edema. Small subcentrimetric lymph nodes were palpate in the cervical region. JP was normal. On respiratory system examination, his trachea was central, chest movements were decreased on left side. No rib crowding, no intercostal tenderness. Dullness present in left supraclavicular and suprascapular and scapular area. Stony dullness present in left infrascapular area. So decreased blood sounds in left suprascapular, scapular, and infrascapular areas. Diffuse wheeze heard in all the both sides on all areas. So other system-based examination was unremarkable. So local examination on oral mucosa is hypertrophic gingiva, thick coated tongue, and erosions noted in the labial mucosa were noted at the extent visualized. Mouth opening was also reduced. Palate, we noted a few erosions. Nasal mucosa was also crusting seen over the nasal mucosa. He doesn't have any fingernails, as anochia was present in all fingers and toes. So syndrome complex of fever and left-sided pleuritic chest pain. So we suspected the differentials like pleural effusion or empyema with collapse because of the tracheal. There was no tracheal shift. And pneumonia with pneumonic effusion and left-sided lung macellation. So we did a chest X-ray. It shows a left-sided homogeneous opacity extending from the apex to the left hemidiaphragm with the inner convexity. So there was you can see an air bronchogram before the actually after the chest, so retrocardiac region. So we suspected a consolidation of collapse may be present in the region. So we sent the routine investigations. The investigations came as hemoglobin initially 7.9. It is the lower range throughout this hospital stay. Total counts are elevated initially 23,400 and platelets is 6,89,000. His creatinine was 0.39. LFT was also normal except ALP. Then electrolytes also is a mild hyponatremia, probably due to dehydration. So we did a pleural fluid analysis. So his pleural fluid was full of thick pus when we aspirated. So pH we have said is only 7. Pleural fluid glucose was less than 5. WBCs were 3,89,653 with 95% polymorpho-neutrophils and 5% lymphocytes. So we apply the lysis criteria. Pleural protein by serum protein is only 0.65. LDH by serum LDH was 133. ADH was 5. So we suspected exudative pleural effusion and we didn't put on ICD for this patient. So before that, we did a CT thorax and abdomen also. It also shows a left-sided local pleural effusion, around 500 cc pus collection, and collapse of the Staphylococcus empyema, like that we are suspecting. But to our surprise, this patient has grown Echinella corrodens in his pus culture. So we have empirically started this patient on meropenem and vancomycin. We sent the meropenem susceptibility also, it was also susceptible. So we were surprising why this patient developed this Echinella corrodens empyema. So we all know this Echinella corrodens is a hazard group of organism. It's a fastidious organism. It causes endocarditis in a patient who is undergone already a dental procedures. So our patient is not an immunocompromised as such, but he's having some skin lesion and from the 3 months of age. So we do literature and search which patients will develop Echinella corrodens empyema and what are the other disease manifestations this Echinella corrodens is. So Echinella corrodens clinical presentations. It can cause a variety of human infection, including periodontitis, brain abscess, endocarditis, osteomyelitis, intra-abdominal infections, and thoropulmonary infections. Can also cause orbital cellulitis, subdural hematemphema, orofacial abscesses, osteomyelitis of the mandible, sinusitis, parotitis, thyroid abscess, temporal lobe abscess, and maxillectomy for carcinoma. So these are the various clinical presentations of this equinolar coronets. So we went into the literature. What are the risk factors for developing this equinolar coronets emphysema? So this is a retrospective 5-year review of clinical trials and laboratory database. So this was done on a hospital in a Madrid. So they collected a 5-year history of equinolar coronets infection. So they found that so they have patients, 9 patients having equinolar coronets infection. So 4 of the such patients is empyema. So some patients have diabetes mellitus. Some patient were having some alcohol abuse, periodontal disease. Some patient was having esophageal disease. Some patient is having already a compromised lung. So possible route of entry, the suspected surgery. Some patients may suspected aspiration. So usually the equinolar coronets emphysema occurs as a polymicrobial infection. Our patient also has a co-growth with Streptococcus intermedius. It was suspected to vancomycin. So these patients treated with some patient piptas, some patient meropenem, metapinum. So our patient doesn't have any such risk factor. Our patient is a young patient. Only the skin condition. We don't find any specific relation to this junctional bullosa with this equinolar coronets. So this is another study. So they found some 6 patients in their hospital having this equinolar coronets infection. There are 2 patients are having chest infection. One was having pleural effusion. One was having some pneumonia. So this patient also, all patients has done surgical intervention. So they also found the past history wise. There's some patients are lung cancer, type 2 uncontrolled diabetes mellitus. There's no relation to any skin condition they have mentioned. So this was the first case of emphysema caused by equinolar coronets. This was recorded in 2011. So 83 years old man who presented with left side emphysema, the culture growth equinolar coronets. So this patient was treated with surgical drainage and appropriate antimicrobial therapy. So they have given a course of amoxicillin clavulanic acid for the past 2 weeks. The patient improved. So they have repeated a chest X-ray after 8 weeks. The emphysema was completely resolved. Recommended. So what are the risk factors for equinolar pulmonary infections? So most occur in patients compromised local defense mechanisms such as increased propensity for aspiration, presence of any underlying disease conditions, and immunosuppression. So because the equinolar microbiology is a slow growing facultative anaerobe. That means it requires a 5 to 10% of carbon dioxide for growth. It's a gram negative bacillus. So it produces a greenish discoloration of underlying agar and a small smell of bleach. It produces a pit on the agar while growing. So its name is equinolar coronets. So you can see a chocolate agar and the growth produces a pit in the center. The treatment, there's no specific guidelines for treatment. So we went through the literature review. It shows that most of the equinolar coronets isolates susceptible to penicillin, ampicillin, second and third generation cephalosporins, carbapenems, fluoroquinolones, and tetracyclines. So important thing to notice, all strains are resistant to clindamycin and metronidazole. So some are beta lactamase producers. So beta lactamase inhibitor should be given. This is clavulanic acid, sulbactam. So besides appropriate antimicrobial therapy, so surgical drainage is must in all cases of equinolar coronets infections. So we went to literature review. All the patients were treated with surgical drainage also. So our patient was treated with we put an ICD. We drained all the pus. But as of now, after draining all the pus in our patient, the lungs hasn't expanded. So what we actually, so we have put a thoracic surgery consult and waiting for any decortication is needed. So our patient, we thought why this patient developed equinolar coronets. So we are probably suspecting because this patient is having excessive mouth ulcers. So equinolar coronets is a normal flora found in mouth. So we are suspecting this due to this mouth ulcers. This patient might have developed the equinolar coronets, and is also chronically malnourished. There is a 18 years old boy with only 30 kgs of weight. 30 kgs of weight. So we are thinking these also the conditions we might have predisposed to patient developing the equinolar coronets emphysema. So the landing points, equinolar coronets are normal flora of oral cavity. So risk factors for invasive infections, equinolar coronets, and antibiotics to treat equinolar coronets.
Thank you, Shannon. It was well presented, and we usually only talk about equinolar, so it's good to see that. I mean, good as in unfortunate for the patient that we had this patient. Thank you for those pictures because I think they're relevant when we are talking about a clinical patient. Just a few questions. Just can you go back to your auscultation findings, please, on the examination? Yeah, I think in going from an examination to differential, some of the findings of consolidation, if it was present, then your differential will become slightly different. Here it was almost like an effusion. I know your differential included a consolidation, you said pneumonia. So that is there. Of course, with a loculated effusion, sometimes the pattern of dullness may be very localized, like you have said. No, it's not. It's only in the left infrascapular area. So because it was in the end-loculated effusion. So just to say that if you are going to, if you go to your differentials, please. Yeah, when we said pneumonia with pneumonia, so obviously the effusion could mask the features of a pneumonia, but maybe you get different auscultatory findings with the pneumonia and a lung mass. If you can just go to your X-ray, please. Yeah, here, looking at it, would you have said loculated effusion? I mean, here you've explained it all, but if you had to see it without that particular thing, how would you differentiate between a loculated and effusion, a normal effusion? When you just look at an X-ray.
Curve.
Yeah, so here the shape of the curve is different, and you can see that it goes inwards midway and then comes out, which you have explained anyway. Okay, so that's just when you look at it, that's why the differential you wonder about a mass also. But a loculated effusion will look slightly different from that, and even a lateral X-ray might have helped, look at it delineated better. Now we go straight to imaging, and this is somebody you would image anyway. So that's fine. The other thing is, I know you did mention that you thought of Staph aureus. Just a Staph aureus by its presentation and this person's presentation is slightly different. He was sick over a month.
1 month. 1 month period.
So sometimes we see more virulent, but occasionally we see longer chronic infections with staph. Why is this? Just to ask a question for my knowledge, you said most of Echinella are polymicrobial. Usually, why is that?
Because it's usually occurs from mouth flora. So mouth flora is usually polymicrobial. So the infection also we got as a polymicrobial.
And unlike the Nepal one where they got a pure
growth.
So the patient is now discharged or?
No, he's still in ward now. His lung hasn't expanded after we removed all the pus. So we're planning for thoracic surgery consult also for decortication.
She's otherwise comfortable?
Otherwise in room at maintaining saturation.
Maintaining saturation, yes. Okay. Any other questions from the audience or somebody online?
No, ma'am. Actually, it was a genetic condition. So no immunosuppression has been given to the patient.
And we can see that in one of the studies, most of the sources were GI, they were all post-surgical in one of the studies that you mentioned, the first one. Yeah. There is some diabetes in one, but otherwise it's clearly all kind of GI sources. One person had periodontal disease, but the next study was more like a medical combination of patients. So I think it's difficult to say. It's unusual at best, but to be suspected, as we say, mostly with endocarditis, we think about it, but we have it as a loculated effusion. So thank you so much, Shannon. That was a good presentation. Thanks so much. You all can clap enthusiastically for your colleagues. It's allowed. Thank you so much. We'll go on to the presentation.